So this is the case. The cases are going to be long, like I was told, very confusing. But I always say, stick with the bars way. And when you find the bars way, just know that that is what you have. They're not going to tell you anything else. And so you have to stick with it. So I'm going to walk through it and you see how I'm going to tackle this question. I'm going to ask you questions and we talk about content. This is the case. A client presents to the emergency room with muscle weakness, right? Racing heart and nausea. Client also reports non-bloody emesis for 2 days. Client has a similar episode 6 months ago, requiring hospital stay. Had not refilled medication for 3 months. No sick contact, no cough, no chest pain. Can you see what is going on? I've given you enough information, but you have to say, hey, is there enough information there, right? Muscle weakness. I did not give you age, nothing. I did not give you a sex, nothing like that. I intentionally did that. Then you're looking for something that you're familiar with, but no, I mean, this is what it will do to you. So we have a patient, whoever it is, weakness, racing heart, nausea, right? Non-bloody emesis for 2 days. This happened 6 months ago. That client was admitted. He's not taking the medication for 3 months. What medication he or she takes? Metformin, right? The client takes metformin and lisinopril, atorvastatin, and enalapril. That tells you the patient has history of what? Hypertension, hyperlipidemia, and type 2 diabetes. This is consistent with that. He also has peripheral vascular disease. Oh, venous disease, that's what I mean. I would just put PAD here. On your review system, what did you find? Client is fatigue, has weight loss, and anorexia for 6 months. When you examine, mucous memory was moist. Had regular rhythm, some crackles at the lung base, abdomen soft, non-tender, non-distended. There's some PD edema on the extremities, right? Cap refill less than 3 seconds, flash 2, peripheral pulses. Let's make this splash 3 bilaterally. This is the virus, heart rate, temperature, blood pressure, and that. And I give you some lab. Sodium, potassium, BUN, creatinine, glucose, phosphorus, calcium, and hemoglobin A1C. Can you see what is going on? Like I said, this is what they're doing to people, and you know the stuff, but yet you're confused. Don't worry about it. Just deal with what they've asked you. Just deal with it, and then go with whatever you think it will be your diagnosis. But you got to, there's certain things that you can see that is abnormal just by reading it. And focus on the abnormal symptoms, and then you can figure out what the problem is the patient is having. So the next question is, which findings are most concerning? So when you see that like that, that means they want you to focus on things that is going to kill the patient now. Now, not something that you think you have time to work with. When they say that, that's what it means. So you don't know what the problem is. You may not have figured out what is the problem. They're not giving you any information, but this is all you have. So which of this is very concerning? I did not give you things you should look for. I want you to yourself look at whatever they've given you and say, oh, this is worrisome. And that is now you should be thinking. And they give you a case, even if they don't select that one, think, I did not select things you should worry about. But I want you to read through the case and say, oh, which one is like worrisome? It's abnormal. It's not normal, right? And by not just normal, but it's concerning, right? Okay. It can be not normal, but it's not concerning. I said concerning. There's the word concerning here. So giving things that you think it may be concerning, not just the lab value. So muscle weakness is not good, right? The heart is racing is not good. Nausea is not a big problem. Yes, emesis is not a big problem for 2 days. It may be related to something that is causing him to vomit, right? Yeah, similar episode 6 months ago. It's not the problem. It just tell you we worry about something that's going to kill the patient, or you need to do something right away. He has not filled his prescription. This is worrisome, right? This is all probably this is why all this is happening, right? But you're not going to do anything about it. But for this one, is because it's part of the history. Yeah, it has to be concerning to you. Why have you not taken your medication for 3 months, and that's why your blood pressure is like that. So this is related to that. Therefore, I have to do something about it. No sick contact, nothing. Weight loss, there's nothing you can do right now. Anorexia, there's nothing you can do. Increased fatigue is related to the muscle weakness. So that's the way I want you guys to start thinking, like, so that they don't distract you. But there's something there you should be figuring out. He has some crackles in his lung base, some edema. But if you look, his capillary refill is less than 3 seconds. His pulse, so that means his pulse is well perfused, but he has +3 pulses bilaterally. It's bounding. If you look at the lab, vitals slightly tacky, right? And the potassium is high. The BU and creatinine also high. Glucose is elevated. Phosphorus elevated. Calcium, everything is abnormal because probably is all this. He's not taking any of his medication. They may probably ask you to select 4, the most worrisome 4 things that are very, very worrisome for this patient. They may not ask you to select all of them. Most likely, the potassium is not good, right? I don't like the potassium. I don't like the blood pressure too. I don't like the lung crackles, right? His phosphorus is not good. This may be related to his problem. So be open-minded and go with the flow. I don't know which one they're going to tell you, but I did not ask you to select. I did not pick one, but I want you to look through and say, there's a bunch of things that is abnormal. If I say most, which one can you put them in a category and say, hey, these ones are really bad? Of course, the potassium is not that great. Edema, crackles, that tells you something is not right. The blood pressure is too high. Those are the 4 things I think I will put in category. The BU and creatinine can be in the same place. So this is the first information, and I want you to think about it. Okay, so as you, hemoglobin A1C is elevated, but can you do something about it today? No, this is 3 months problem. So you may see that underlying, but if I'm taking the test and this was underlying, I'm not picking it. It just, there's nothing I can do when they ask me for most concerning. Most concerning means I can't do something about it right now. I can't do anything about hemoglobin A1C. I can fix the potassium, right? I can fix it. I can fix the blood pressure. I can fix the crackles, the PD edema, and maybe the phosphorus. I can fix it. That's the way they want you to think. And if I fix the potassium, probably I may fix his muscle weakness. Okay, so that's the fix portion of the case. Any questions so far? If you have a question, you can type it. But this is the first portion of the case. What intervention, what would you do for this patient? If you are the doctor or the nurse, what do you expect? That will begin. If you are, so I said the most concerning is potassium. I'm worried about the potassium. Is blood pressure. I'm worried about it. The edema, it's lung crackles. These four. The muscle weakness is related to his potassium. And if you are the one, what intervention? What would you do for this patient? Okay. So if you anticipate this, so that when they give it to you, it's not a problem. Somebody say EKG, excellent. So somebody want an EKG. So we have an EKG here. So our plan is to get an EKG. They're making it try to hide things, but it's the same thing. So when you go and you panic, like I said, expect things you may not know, but you have it. You have the information. It's not like they're making it hard. You know the thing. You just have to say, hey, okay, it's another beast. Let me deal with it. Somebody say cardiac monitor. Okay. That's what you want to do. I don't know about elevate head of the bed. Okay, for the crackles, sure. And giving IV fluid. Why do you want to give this patient IV fluid? Insulin and B5. So why do you want to give this patient IV fluid? I don't understand. So you want to give insulin, you want to give D50. But why IV fluid? A potassium of 6.5. We don't need to infuse more potassium. So we don't need any more potassium. Potassium is 6.5. If you infuse potassium, we're killing this patient. So no more potassium. Somebody said chest X-ray. Somebody said paracetamol. Okay. What else? So far, I mean, I like what I'm seeing. Okay, so this is fine. How about if I tell you we need to get a CT scan? CT scan with IV contrast. Do you want to give this patient CT with IV contrast? So we don't need to give them CT scan. His creatinine is already 3, so we don't need to do that. How about if I say albuterol? Will anybody give this patient albuterol? I can see you guys treating the potassium. Yeah, if you're treating potassium, then albuterol is used for potassium. It's one of the things. It would decrease potassium. So albuterol is indicated. If I say, well, let's order some diet for this patient. Okay, let's order some diet. If I order diet and I give you like high protein diet, anybody is okay with that? And high salt diet. Do you want to do that? No. So everybody said no. Yes. So that's good. Now, so you know what you're going to do for this patient. We give this patient laces. I'm not telling you the problem, but we're fixing the problem so that you don't say, hey, okay, now, you know, things that are abnormal, We're trying to fix things that are abnormal, right? And we give the patient lasers. It will help probably with the crackles and a plus 3 and peripheral pulses. KSLate will help with the potassium. Calcium gluconate will stabilize in case there's a EKG changes that we obtain. We put in the patient a cardiac monitor to take care of the potassium. We're not giving them high protein diet because his creatinine is too elevated. Insulin and this will take care of the potassium. Albuterol take care of the potassium. And chest X-ray will look at the crackles in the lung. Probably this will help with the weakness and all these things. And that will help with the patient. But nobody giving him antihypertensive, right? Why? Not clear on albuterol. Albuterol will push potassium in the cell. So albuterol is used to treat potassium, hypercalcemia. So nobody is treating his blood pressure with antihypertensive. Why? So why will you not give specific blood pressure? Furosemide is not mostly for blood pressure, you know. Yeah, Benny Love said because of fluid overloaded. Yes, it's fluid overloaded. You don't want to give him any antihypertensive now. It's fluid overloaded, so the lasers will take care of it, and that will drop his blood pressure. Probably there's something there. So this is good. I like that. So that's the thinking I want you to go, the thinking process. So if they give you this and they're trying to hide things here, okay, we know the patient is fluid overloaded. Now let me give you the idea. We know his patient is fluid overloaded. His potassium is high. His phosphorus is high. His creatinine is high. He has diabetes. He has hypertension. You should be thinking about something, diagnosis that will give you all this. Put it together in your head. What condition will give you this kind of, I have diabetes, now I'm fluid overloaded. My creatinine is high. My potassium is high. Phosphorus is high. Calcium is high. I'm not telling you, but you have to figure it out as we continue with the case. Now we get the EKG and we have peak T waves and then PVCs. You guys already give me the plan. We already done that already. So you treated the potassium already by getting the EKG and it showed peak T wave. And we already giving all the medication that we need to treat the potassium. You see how they can go through the case, you know, then they can give you, say, which is this is indicated. All the things we did earlier on, now you're seeing it. They can actually like that. Say, oh, okay, I know it already. I was thinking before. Now you're asking me, you get an EKG. So it will become, the case become easy. You already thought about it. Hey, potassium is abnormal. These are the things I expect. Now I'm asking you, what are the things you need to do? We don't have to list them anymore, but you have already figured out what is the problem and you already know what is expected. And you're already thinking about it. You are ahead of the examiner and you have done it. Okay. So now we did everything. We did everything we can. Client urine output still, it remained very low despite all measures. It's no peeing. What should the nurse anticipate? We've treated the potassium. We've done everything. We've given furosemide. So K treated, okay. We're giving the laces already. He's on a cardiac monitor. He's in the ICU. We've done everything. Still, the client is not peeing, no urine output. What should the nurse anticipate? Give him care, selecting everything. Remember, this happened 3 months ago, but now it's not progressing. So what do you expect? So now you want to dialyze the patient. I like that. So we're going to dialyze the patient. You see, I've not given you the diagnosis, but you can figure out, what is the problem now, right? So you will dialyze the patient. What kind of dialysis will you do? What are your options? So we have hemodialysis. Most people say hemodialysis. And then some say PD. So we have two options. Either we go the hemodialysis route and the PD route. In this situation, what do you think you will need? You can go either way. If we have to do hemodialysis, what do we need to do? Hemodialysis, there's two types, okay? We have a temporary one and a permanent one. We cannot do permanent because you have to give them a fistula, right? There's two types of fistula. There's a graft and the main fistula. The graft is, if this is the vein and this is the artery, you connect it, where is it? You connect the two together with your body vein. This is your own vein. With a foreign object. So this is a foreign object. But for fistula, you just connect the artery, the vein together. Okay, so these are the two options. Either you use a graft and connect the artery and the vein together, or you use the body-owned artery connected to the vein. That would be the fistula. This takes some time to mature, so you cannot use it right away. We can place a catheter, temporary catheter, to dialyze the patient, usually in the neck. So that is the temporary double lumen. So like a double lumen, this become a double lumen catheter for the dialysis. Okay, so those are the options. The PD is easy. You can do it now and then use it. So it's placed surgically. You go to surgery or sometimes on the bedside, but mostly surgery, and they put the catheter into the abdomen and they do it. So those are the two options. Most hemodialysis, graft and fistulas take like 3 months. The PD usually you can use it the same day or the following day. The temporary one, you can use it the same day too. So temporary dialysis catheter and PD are almost equivalent in terms of their function and when you can use it. So now let's go back. So we've decided, assuming we want to use PD first. So that is the content right there. So we want to use PD, peritoneal dialysis. Now, these are the things the nurse who is taking care of the patient is doing. Tell me if this is good or bad. So weighing client before and after the dialysis too. So she wearing sterile gloves, masks. Okay, what does this do? The disalate in the refrigerator. And then infuse right away. Okay, the efferent is colorless. That's what she recorded. That's what she expects, right? And placed the drainage bag at the level of the heart. Tell me, is it bad or good? And then recommended, she had a client, so it's 8 clients sitting or laying down. as you can see, this is fine. You have to weigh the client before, after. You got to ensure sterility. So you wear sterile gloves, you put on a mask. The dialysates need to be warmed. It's a special warmer. If they put a microwave, don't pick it. You cannot put it in the microwave. Okay, it's a special warmer that will warm the dialysate. The effluent should be colorless, and the drainage bag not at the level of the heart. It's below the insertion site. So it should be down here like that so that it can drain by gravity. High fiber diet to prevent constipation. And a client can be sitting, they can sit down or lay on their side. So you can either lay on the side or you can sit down for drainage. So this is okay. So these are things you should expect. They may go through that process and ask you and all those things that you should worry about. Okay. Remember, there is a 3 phases with dialysis, hemodialysis, and PD, right? There's the field phase, there's a dural phase, and there's a drain phase or drainage phase. These are all prescription the doctor will prescribe based on the patient needs. So it's not constant for everybody. But most of the time, the infusion is like 30 minutes, The draw is between 4 to 8 hours, on average. And the drainage is also 30 minutes to an hour. But it depends on individual patients and the prescription that will be given to you, and then what you need to pay attention to based on the doctor's. Okay, so that's that portion. Now, patient, the nurse is draining the thing, and all of a sudden went and did some vitals. Okay, and her temperature is 101.5. Like 3 days later, while the patient in the hospital, there's a redness around the insertion site. Okay. The affluent, that means whatever is going on in is greater than the effluent. Okay. Patient WBC is probably 14,000. His heart rate is 107. What else? And the last one, effluent, is blood tanked 24 hours after placement. Not all of them. Not all of them. So these guys stream infection. They scream infection, efferent infection. Green efferent and feculent is perforation. You perforated the bowel. Bloody vessel, you perforate some viscous or blood vessel is being injured. Efferent, blood tank 24 hours, this is normal. And if the client is female and you see pink output 24 or drawing effluent, the next thing you ask the patient is what? It's a female and you see pink output coming out from the effluent. What do you ask? What's the next question you ask the patient? Are you having your menses? So that's what you asked. Are you in your menses in the middle of the month or end of the month having your menses? So those are the keys you can distinguish between the two things. Okay. So you see, we're going through the case easily, flawlessly. and you're getting it. So if you see something like that, don't panic. I've not told you anything. You're going through the whole thing. So those are the things you should be like thinking like they can ask you. Okay. If the patient has cramps, okay, you're infusing, they have cramps. What would you do? Slow down the rate. Just stop it and then slow down the rate. What are the things you need to notify the doctor? The input is less than output. But then before you call the doctor, there's things you can do. Don't call the doctor because the input is greater than the output. Yeah, you have to call the doctor, but there's things you have to do to fix it first. Okay, try to put the drainage bag in the dependent position as much as you can. Look for kinks. If there's kinks in it, take them out. Okay, let the client change their position. Okay, if none of them work, they can walk. Assist them to ambulate. You can still walk when you're having peritoneal dialysis. It's not a problem. Okay, then you can assess for constipation. If there is constipation, yeah, bowel regimen, right? You provide for the patient as much as possible. But those are the things. Then if all these things, oh, okay, then you can call the doctor and then let them know about it. Expect them to trap you, okay? Then abdominal pain is not the same as tenderness around the insertion site. So peritonitis, when you have peritonitis, is not the same as insertion site pain. So when you have insertion site pain, it may just probably some superficial infection there. It's different from peritonitis. That's what I told you about. The efferent is cloudy, tachycardia, white count is high, patient has abdominal pain, cloudy. And remember, when that happens, you got to send culture and sensitivity, then antibiotic. This can be a question they can ask you. How do you give antibiotic? You suspect patient has infection of their PD and they have peritonitis. What would you do? You stop the PD and then you give them antibiotic, and how? You stop the PD and then give the antibiotic. How? How do you give it to them? So this is one of the benefits of the peritoneal dialysis compared to this. You don't stop the PD, the antibiotic, the peritoneum is infected if this is the individual, right? And they have catheter going here. The infection is not systemic unless it's really get bad, but it's called a spontaneous bacteria and peritonitis. It's inside, infectious problem right here. Well, we can infuse antibiotic through here like that, boom, and you go and treat the infection inside the peritoneum. And you can still do your peritoneal dialysis. So you don't have to stop it completely. So the antibiotic can be given through the peritoneum. So you can do that easily, and that will not prevent the individual from getting dialysis. So that's another thing you should know. You can give it through the catheter. So you can get an infusion through the catheter, and that can deal with it without any problem. Okay, so Now, any question? The best route is through the peritoneum. You can give it, if you get infusion through the peritoneum and watch the bacteria and kill the bacteria there. If that's not efficient, then you can give it IV route. We don't want to, PO is the less important. You put it through the catheter and you get into the peritoneum and deal with it. Okay. Patient, well, let me see where I can take you. So, patient hemoglobin come by CBC and it has hemoglobin of 9. Okay, 9 grams per deciliter. And probably hematocrit is like 28. And the doctor order Epoetin alpha. I'm testing you guys today. How can you give the Epoetin? Which way? Route. And what do you need for the Epoetin to work? What is your priority when giving Epoetin? So there's a bunch of content here. This is the whole case. I'm trying to like give it to you. So this is given through sub-Q or IV. What you need to work, think about it. We're going to make hemoglobin. So of course you need iron, right? So you can give iron infusion in addition. They also need vitamin B12 and folic acid. What is your priority for Epoetin? The key is we want to increase your hemoglobin by 1 gram deciliter or stop the medication if it's 11. The hemoglobin go 11. So from 9, we can go to 10 or we stop it when it's greater than 11. As soon as we get to 11, we're stopping it. And our priority is hypertension. Every time you see Epoetin question, think about hypertension. It can increase hypertension, and that's a priority. Anybody in Epoetin with hypertension, it's a priority. They have the blood pressure will be elevated. They get the ICP issues, and it will become a problem. So don't forget, this is the patient that will be on Epoetin, and it's all part of the thinking you should pay attention to. Any question? Now, patient has to go home. Well, you got to teach them how to take care of their hemodialysis, right? The peritoneal dialysis. It's the same teaching, This is the only, I'm writing it in capital, only thing in, I guess not only, but one of the things you have to teach client aseptic basically aseptic way of taking care of this. They have to do the same thing you did. So you got to teach them to wear gloves, okay? Wear masks when they're infusing, and then make sure they clean around the site. Okay, the same thing that we talk about, you have to teach them this. It's very, very important. Sterile dressing as much as possible. When the dressing is wet, it's not sterile anymore. You got to make sure it's dry as much as possible. And what is the number one thing you should tell them apart from wearing gloves, masks, clean the sites? What is another important thing you should tell them at home to do every time? One thing, if you have to tell them one thing. They have to weigh themselves back. One more, the most important. Wash your hand is also aseptic. First night, yeah, it's the same thing. Wear gloves. Is a priority. One thing they have to actually do. All you guys, what you say is right, but there's one thing that you got to remind them. Check their vitals frequently, okay? Because if they temperature and tachycardia, and hypotension, you know they're getting sepsis. So you got to teach them to check their temperature and vitals at home. Very, very important, so that they don't get sick from it. Okay, so that's that thing that you teach them to pay attention to. Now, assuming, well, the patient said, I don't want peritoneal dialysis. I don't want somebody to poke my belly. Well, we know we can place a temporary double lumen catheter to use as a hemodialysis. So you can do that. You can use it as a hemodialysis. And then in case that's the way you have to deal with, you got to do the same thing. Hemodialysis, there's certain things you have to know about this, right? He's doing the same thing. He's going to dialyze the patient. Like I told you, I explained the graft and the fistula to you. You need an access. So the procedure involved, we assess the whatever catheter we're going to use. You're going to Epoetin the patient. This is key. So you, the nurse, don't give them their anticoagulation. If they're on anticoagulation and they give you a question, and they said, what do you do before they go to dialysis? Don't give them anticoagulation because they're going to get heparin during the process. Okay, so we assess the site and heparinize, then dialyze the patient. They can eat breakfast. They can eat during dialysis and before. They can eat. So if they're diabetic here, you can give them their insulin and you give them food so that they can eat. You can't hold their medications to do that. There's few medications you have to hold. You know, anti-hypertension, blood pressure medication is not good. You know, it just like it make them more hypertensive and it become a problem. So we want to hold these antihypertensive as much as possible, but the patient can eat. Okay, they can eat easily. So just make sure you know about that. There's medication that can be washed out during dialysis, like the digoxin, like that can be washed out, and then water soluble vitamins like C, B, you know, and some antibiotics can be washed out. Some antibiotic can be washed out. So that's antibiotic. Why do you hold antihypertensive? Because their blood pressure is going to drop during dialysis. So you want to hold it because then the blood pressure will go down. The insulin I said they can eat. So if they have diabetes, they're diabetic, yeah, you can give them their insulin with your food so that they can eat. It's not a problem with that. That's what I mean by that. They may trap you. There is a medication, I've said some of them. Medication, if they ask you, say they put insulin, let me see, heparin, calcium, these are given to them, and insulin. This is okay during dialysis because we give them heparin during dialysis. We also give them calcium and to help with the blood, so they get some calcium. And then the insulin, I told you, if they have diabetes. So don't hold those medications, but don't give them the heparin before they go to dialysis, because then their blood is already thin. This will be given during the dialysis aspect of it. So these medication, if you see it, don't pick it. Heparin, calcium, insulin can be given to them during dialysis, and they can eat during dialysis and before. Yeah, you give the insulin with food. So let me see, let me clean this. Of course, you have to worry about some complication. They're going to take you there, okay? Right? Air embolism. You can have disequilibrium and syndrome, right? So those are the things you have to worry. They can have sepsis, infection, they can have hypotension, the machine can clot. So clotting, all of them can happen, basically. So these are some of the complications you should expect them to ask you if they're dealing with. They can get a cardiac arrhythmia with the change in and potassium and other things. So just know. Air embolism is straightforward, right? They will tell you what patient all of a sudden is getting dialysis, feeling of doom, tachycardia, restlessness. You know that's bad, right? Hypoxia. Yeah, that should be your first idea that, oh, this is not normal. Okay, this is not normal. They're not going to complain about headache like this equilibrium or nausea. This equilibrium usually will give you nausea, headache. Yeah, that's the difference you can tell. These people are not going to compare. All of a sudden, feeling of doom, and then they feel like they're about to die. So what do? First, don't call the doctor. I want you to clamp the catheter first. Okay, clamp it. Then put them on the left side, left lateral, and their head down. Okay. So that's the key. You give them oxygen, and then you call the doctor. Okay. You call the doctor, MD. But never call the doctor. Don't put oxygen on. Don't put the head down. You got to clamp thing. This is the catheter. Air is rushing through. Clamp it first. Then you put it on the left side, head down, oxygen, and then call the doctor. But this equilibrium is different. It's due to mostly first dialysis. This is their first time. Okay, and it's due to changing intracellular, extracellular fluid level, and then they look like somebody who have ICP issue. Okay, so they have nausea, vomit, and they get a headache, and they become restless, agitated. So agitation and restlessness. When you see that, okay, it's usually temporary. Okay, But they're going to ask you that you don't know what is the first thing. They will give you so many things you don't know what to do first. First, just stop the infusion, okay? And slow it down. So stop the infusion, then don't treat them. After you stop it, don't treat them because you don't know how it's going to progress. Is this going to get worse? Because it's an ICP problem. So when you stop the infusion, you notify MD. So you call the doctor. After you stop the infusion, you call the doctor as soon as possible. And they can give you orders, then you can do the other thing. After you stop the infusion, call the doctor, then you treat them like they have ICP issue, less stimulation, prepare to give them, I mean, I don't have to go all into detail. I expect you to know this by now. It's an ICP problem. So this is disequilibrium syndrome. So you stop the infusion, call MD, then treat them like they have ICP. So low stimuli, okay, no stimulation as much as possible. Prepare to give them hypertonic solution to pull blood from the brain. So mannitol or 3% normal saline, right? Of course, head of the bed, at least 30 degrees. But these are not important until you stop the infusion. And this is temporary. They will still need dialysis. So if they take you there, they say, what next? After this resolve, it means you start slowly. So slow rate and less time. This is the key. So if the dialysis is supposed to take 8 hours, for this patient who has developed this, next time, 4 hours, slowly until they mature to that place and they get comfortable with that. Okay. Any question? I think so. This is, we kill the question, everything. So the patient have, now I can tell you, patient, let's go back. I'll tell you what he has. You know it, but I hope by now you figure out. He has chronic kidney disease. It's not acute problem. The key fact is this happened 6 months ago. He has hypertension and diabetes. His creatinine is too high. This is all potassium problem. And he was fluid overloaded because he wasn't taking his medication. And when he developed acute on chronic kidney disease, so CKD patient. And then we treated him accordingly. So this is just the recommendation from, this is not the question they got. I mean, based on what the patient told me, like, this is how they're doing the case. I figured today I wanted to show you how the scenario would look like, because in case you see that, for non, I'm saying this is not the case the patient got. Okay, they provide the nurse got. I'm just using this kidney disease to show you how I can give you a case, and I never told you what the patient. I never even asked you what is your diagnosis. I just went through what I expect you to know for that particular, and you stick with it. As soon as I see you guys treating the hypercalcemia, something should be ringing that, oh, okay, and you have to put it together. Hyperkalemia, low potassium, high potassium, phosphorus is high and calcium is low. That's classic kidney issue. But you figure it out, and so you stick with it. You don't like get trapped with anything. Every question you're going to answer is related to, I think this patient has a kidney problem. No matter what they throw at you, he has a kidney problem. If it's number 6 question, is a kidney problem. I'm sticking with it and I'm answering it in terms of kidney. Otherwise, you get confused. You answer question 1 differently, question 2 differently, question 3, and then you get everything wrong. And that is, they've given you a case, you stick with the case if you figure out. If even they don't tell you about what the patient has. Okay, any question? I think I've exhausted it. I just wanted to demonstrate it to you guys, to show you, like, I mean, they adapting. They can know, people now know how they setting the question, but you also have to be, especially the cases, the cases can throw you off and it can put you in a, as soon as you start having problem with it, you lose focus. But I don't want you to, when, even if you have problem with one, just say, oh, okay, now I figure out the next four. If you're getting five, don't get distracted. Okay, if you screwed up one and you figure out the first one, say, oh, this is the way they're asking it. The second one, you say, okay, if this is, I think this is a MI, I'm sticking with it. I'm answering it in MI so that I don't get distracted. Okay. Any question? So this is like, I do not want to give you, I use this peritoneal dialysis and hemodialysis to use it like how I can start from somewhere. I will take you left to right. We treat about potassium, how to manage, how to prioritize a kidney patient, what you need to do for dialysis patient, what you need to do for somebody indication for hemodialysis and peritoneal dialysis, what you teach the patient, what are the priority functions, the medication, Epoetin, what you expect in kidney disease. And then this is like a full lecture, but you did not see that. I saw everything. I give you all the EKG. Okay, guys. Thank you for coming. If any question, let me just stop there.